So when they first told me I had a tumour on my spine, it was very sobering. One of my concerns was obviously being paralysed.
If it's not treated appropriately, Gary may die. It's a time bomb.
Margaret has a spontaneous hole in her skull. It has the lining of the brain coming down. If we don't fix this, it can be life-threatening and have some very serious morbidity.
This is an opportunity to give me some quality of life back.
Oh my. Oh, this is paper-thin diaphragm. Look at that. An endless amount of possibility of things to go wrong.
So Gary is a 61-year-old chap who's got a spinal tumour, and if it's not treated appropriately, Gary may die. Gary's tumour at the moment is localised, it's in one place, but at some point it may spread, and I don't know whether that will be today, next week, next month, next year. It's a time bomb. The biggest risk is not getting the tumour out, the tumour coming back or spreading. It's a big operation. One of the complications is damaging the spinal cord. If it happens, Gary will be paralysed. Morning, Gary.
Mel?
How are we doing?
Yeah, I'm okay.
So you've got this thing, this paraganglioma,
Yeah.
that we're going to take out.
Yeah.
Okay. So it's a big operation.
Yeah.
Okay. We're removing the tumour and some clear tissue around it to make sure we get it all out.
Yeah.
Okay. It's going to take a long time.
Yeah.
You're going to be a bit sore afterwards, and your recovery will take quite a bit of time.
Yeah.
Now, we hope to do this all by one cut down the middle of your back.
Yeah.
Okay. But the tumour is close to the aorta, the main blood vessel out of your heart.
Yeah.
When we put you on your tummy, we expect that the aorta will move forwards a little bit and a gap will be created, so I'm hoping we can get it all out from behind.
Brilliant.
But as we discussed when you're in clinic,
Yeah.
if we need to, we'll put a cut in your side
Yeah.
just to help us and make sure we can get it out safely.
Yeah. Really appreciate
See
it,
you in
thank
a
you.
bit.
This started back in September. I was in bed one morning, and then all of a sudden, with the excruciating pain, the only way I could get out of bed was the paramedics were called, and they dosed me with morphine to get me out of bed. So obviously something was serious. So when they first told me I had a tumour on my spine, it was very sobering. One of my concerns was obviously being paralysed. These paragangliomas are very rare, and it secretes adrenaline, so your heart races. So that's another major reason why they want to do the operation, because eventually it could quite easily lead to cardiac arrest. Did it make me think about dying? Yes, I guess so. I have a daughter that's got Down syndrome and autism, so we try and shield her from all of this. She knows that there's something going on, to the point where one day I'm sitting on the sofa, she comes in and she says, "Are you going to die then?" Very black and white.
Excuse me. Thank you. This is Gary's tumour. This is his spine here. The slightly paler dot, that's his spinal cord. The big black circle is his aorta, the main blood vessel out of his heart. And the bright area, that's tumour, and it's actually infiltrating the bone just here. The idea when you resect any tumour is to remove all of it in one go. So we're going to cut across there, across the vertebral body, and then we have to come all the way around the outside of the tumour, and the rest of the tumour will come out. It will look a little bit like a lamb chop. It's probably the best description of it. The margin is the biggest determinant of whether it will come back. So the wider the margin, the better. Ideally, if we can have 5, 6, 7 millimetres of bone in the spine, that would be great. Not getting it all would mean that we haven't achieved what we planned. We put him through a very big operation, and potentially we may have compromised his outcome. Morning.
Morning.
Come and join my parlour. Being a surgeon puts you under a lot of pressure. How you manage that varies from surgeon to surgeon. What I remember is this is what I've trained for. All surgeons have complications, and I've had patients and operations that haven't gone well, and you do remember them. Operating around the spinal cord is delicate. There's no sudden movements. If you're rough with it, then it will misbehave. And it's not me as a surgeon that will pay the price. It's the patient that will pay the price.
Gary, can you open your eyes? Okay, so he's asleep now. Thank you.
And plan procedure?
There's en-bloc resection of a T7 tumour.
Expected duration?
It'll take all day, but we'll finish on time.
Okay. Potential significant blood loss?
Yes, there will be a lot.
Do you need both protons and TED for stop?
Protons, TED. Okay, start. Thank you. Starting. So now we're just stripping the muscle off the back of the spine, just exposing the bone at the back of the spine. Tumours have a natural capsule around them. It's rather like the tumour cells are all inside a balloon. And what you're trying to do is take the balloon out from inside the patient without actually bursting the balloon. You will get tumour cells leaking out, so you find that the tumour can seed further up the spine or lower down the spine. The tumour ruptures. It is a potentially significant event. Oh, bleeding. Bit of bone wax, please. As we're removing part of Gary's vertebra, it will leave it structurally weak, so we need to give it some support and put some instrumentation in to provide that support. So what we're going to do now is make a hole in the bone, put a screw into the bone, and just take an X-ray to make sure we're at the right level. To provide the support to Gary's spine, we're going to put 2 screws above the defect on each side and 2 screws below the defect, and we'll join those together with the titanium rod. So that's the screw that's going in. That's 5.5 millimetres diameter, 15 millimetres long. If it's too far towards the middle, I'll put it through the spinal cord. If it's too far up or down, I'll put it through the nerve roots leaving the spine. If it's too lateral, it'll go into the lung. If I go out the front, we could hit esophagus on this side, cut it aorta. There's certainly not a lot of room to play with. Okay, should we take an X-ray and make sure we know where we are?
X-rays.
So what we can see is 12, 11, 10, 9. So those screws are in T9. So we know this tumour is the level, 2 levels above that T7, T8. I've got 6 more screws to put in and the rest of the construct before I can remove the tumour.
Margaret has a spontaneous hole in her skull. This hole has brain fluid that's coming down. It has the lining of the brain coming down, so that as well as there being clear fluid dripping out of the nose, there can be some brain tissue hanging out as well. And then the bugs in the nose can go back up into the brain. And she's already had a complication from it. A few months ago, she developed meningitis, which in itself can be life-threatening. And now that she's better, we're back to looking at how we plug the hole, and we're using a novel approach.
Okay,
Right, so come and have a seat.
thank you.
Tell me now, right from 2016, about fluid dripping from the nose.
My nose has been dripping for a long while. I used to just walk with a bath towel over my shoulder.
Yeah.
If I bend my head, it's like you open the tap. It's just clear fluid coming out.
And all that was the fluid that bathed your brain, CSF.
Yeah. One day I woke up and my head was, when I say bang, it was the mother of all headaches.
Yeah.
I'd rather give birth than that saying something. My son here took me to the hospital. They said, you've got a temperature, which I wasn't feeling, I didn't know.
Yeah.
And they started giving me meningitis treatment.
So this is your scan from 2 weeks ago.
Okay.
In the back of your nose, there's a bony defect between the skull base where the brain is
Okay.
and your nose. I believe that because of the location, it'll be really challenging to get through the nose because it's going through and then it's all the way on the outer aspect at the back of your nose.
Okay, I understand, yeah.
And if I were to do that, I would most likely injure one of the nerves that will cause numbness over your cheek.
Okay.
So the proposal is we make a skin crease incision in the upper eyelid.
Okay.
So risks of surgery, there's a risk of bleeding, there is a risk of infection and a tiny risk of losing your vision. Occasionally the pupil can change shape.
Okay.
But it shouldn't do.
Okay.
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 Is there anything you want to ask me? I've given you lots of information.
Yes. I understand. I understand.
Okay. See you soon. In its simplest form, we are taking some fascia, which is like leather, from Margaret's outer thigh, and we're going to plug the defect. This is a 3D printed model of Margaret's skull. We're going in from the orbit, and we're going to make a window in the back of the orbit, and once we're through, we'll come out just here. And when we come out, we'll lift the lining of the brain. This is our defect, and that's where I'll be sliding in a piece of fascia to plug the hole.
Good morning.
Hello.
Just get his brakes.
A concern in the operation today is that while doing the procedure, we create more holes in the lining of the brain. This would increase her chances of an infection. It's certainly not a straightforward case.
There you go.
Thank you.
You're welcome.
Having had meningitis, I've escaped death. I escaped and I came out with all my limbs and everything intact, so I give thanks. You know, it's a scary thing, you know, because that's what took my mum. My mum died of meningitis, so for me to have it and my children to hear that word, it just instills fear to a degree, in all of them, including me.
Okay, we just reverse it.
Yep. I'm glad to get this operation and it puts it to bed once and for all and just get on with life. No more meningitis. See you, darling.
See you in a bit.
Oh, thank you. Thank you, babe.
All right, love you.
Love you too. See you, darling.
We pick the treatment option that is going to give them the best chance of good outcome with the least chance of morbidity. If Margaret has an ongoing fluid leak, then the bugs in the nose can go back up into the brain and give her meningitis again and again. In operations this complicated, I rely on all the team and their expertise.
So what I'm going to do is set up the navigation scan. So we've got these LEDs, which are 32 in number, and these LEDs correspond to the infrared light over here. And what this does is, it helps us to register the surface of the patient. So as we drill the orbit, it is going to act as a sat-nav, and it will help us locate where the leak is. Can we have the shuts go down, and can we start the recording as well, please?
So what we need to do is to essentially have enough access so that we can safely hold the eyeball out of the way whilst we go down and make a window in the back so that we can lift the lining of the brain and find the defect.
Can I have the blade again?
Beautiful. So we're looking at now the outer wall of the orbit, and we're just going to work out where we're going to make our bony window. We have the pre-operative scans of the patient, and we can use that to help us. Can I have the image guidance, please? We want to get our registration as accurate as we can, because as we start to delve into the back of the eye, what we want to do is be with sub-millimetre accuracy of where we are. Any wrong move could damage other cranial nerves that run through her skull. So this is where we will make our window. So we're going to go in just here. That's it, yeah. Can I have the drill, please? We're now going through the bone in layer by layer. We want to find the lining of the brain, the dura. The dura is the last barrier that sits under the skull, separating the nose and the brain. But it's less than 0.5 millimetre thick and is easily damaged. I can very gently just fracture the bone and get to it. So you see, we're almost through, so we gently just keep going. So we're through the bone and we're looking at the lining, the dura. And so what we're going to do is very gently now to remain outside of the dura, the lining, and make our little tunnel here. See here, this is the dura. Yeah. So we're just going to lift this up until we see the hole going down. So this is where the defect is. The challenge now is to fix the defect without causing any harm.
So that's all the metal work in. Next, I'm going to cut the vertebra in half. It's got the tumour attached so I can remove it. So that's an osteotoma chisel. That's going to basically go alongside the spinal cord, and we're going to hammer that through the bone to the front of the spine. That way above, that way below, and then sequentially that way. So we create a block of bone that we've freed that we can then start to hinge out. This is the bit that's the greatest threat to make him unstable hemodynamically. And if you want a bit, what's the most risky bit to his life, it's probably this bit. Yep. Stop, not so fast. The biggest issue we're going to have is these tumours secrete noradrenaline amongst other hormones, and that can affect the blood pressure quite significantly. And if you get a sustained rise in blood pressure, there is a risk of the patient having a stroke.
Blood pressure is going up.
Have we just stimulated it a bit?
Yeah, it started going up now.
Go slowly because his base heart rate is not really in. We'll be happy at around 140 systolic, but it went up to 190, so it's coming down.
So we're basically starting the longitudinal cut. So we're cutting down the length of the spine, effectively splitting T7 and T8, and we'll remove the left half together with the tumour. It's just a little bit scary because we're cutting through a bone. We can't see exactly how far through we are. If we're too far through the front, we'll cause all kinds of damage by damaging big blood vessels, lungs, gullet. Lots of things we don't want to hurt.
And you can see there the response has gone up because of the pressure they're putting on the tumour. The blood pressure's really gone up, so we need to try and control that now.
It's gone up to 200 systolic. Okay. So let's stay away from it for the time being.
We'll start the selfie.
Yeah. Just give us a moment just to let things settle.
When these things happen, your blood pressure goes up, but your heart rate drops. Blood pressure's that high, but it blows a vessel in his brain and has a stroke. It's the difficult bit where we've got to develop the plane between the tumour and the aorta. There'll be a lot more manipulation of the tumour potentially. Even if we try and avoid it, it will be more, and it'll be for longer periods. And running him with that systolic for a long period would not be a good idea.
That bit of touch has obviously squeezed all that.
That sort of just suggests that we're not going to have a lot of leeway here. If this either is going to be very easy or it's going to be a thoracotomy. Because if we've got to start manipulating the tumour to get that play between the two,
then
you're not going to enjoy it.
It'd just be easier just to do the thoracotomy then, wouldn't it?
Yeah.
So that's come back.
Yeah. It's coming down, let's just give it a bit longer.
Even quite gentle retraction on the tumour has caused release of adrenaline. The blood pressure spiked to over 200, and it's only once they released the pressure on that, combined with us going up on those drugs, that settled the blood pressure back down. So that's why sometimes you might have to think, look, the long-term plan or the better plan in this stage will actually be to close up the back, we'll flip him over, and then we'll reposition him on his side for the thoracotomy. So it might add an extra hour and a half or something like that, but it might be the safer approach.
So, Tish, it feels like the aorta has fallen forwards a bit. I can feel a plane between the two. The bone must be pretty free because the whole specimen is moving. Things that we can only access through the back of the spine, we have done. We've got to come to the fork in the road where we have to decide yes or no. And we might get away without doing a thoracotomy, but it is going to be quite hard. And the concern is we could spend 2 hours, 3 hours trying to do it without a thoracotomy, only to say, look, we can't do this, and we end up doing a thoracotomy. Surgery is about making decisions. Just prepping for the thoracotomy. So he's lying on his side, left side is up. As you can see, we've got a little line roughly where the cut's going to be, and that marks really where his shoulder blade is, because obviously that kind of gets in the way. When he's on his side, instead of having the aorta behind the tumour as we look at it, so we have to work round the tumour, he's going to have the aorta in front and the tumour to the side of it. So we automatically come into the plane between the two rather than work round down the side of the tumour and into the gap between the two. We come directly down into that gap. So there should be less manipulation of the tumour, which means that we shouldn't get the blood pressure spikes that we saw before. For something for the cell saver, thank you. Are we okay to start?
Yes, please, yeah, thanks.
Yep, gents. There's an old adage, you make bigger mistakes through smaller holes. So don't compromise your surgery just to make the hole as small as you can. Keep the rib. Spare ribs. Okay, you got a pair of non-tooth, please? And a pair of Mackindos. So when we get the retractors in, we'll get to our first look, proper look at the tumour. It's about that size. So that's the tumour. Next to it is the aorta, and the spine is under this membrane here. So we'll be taking, what we're taking out is this bit here. We'll see how close the aorta is to the tumour. If the gap's not very big, that increases the risk of damaging the aorta or tearing the blood vessel. And obviously, if we get a hole in the aorta itself or we tear a segmental off, that can bleed quite badly and can be a bit of an emergency to deal with. Not yet. There's just a tissue called pleura that's sort of holding it, so I'm now just, I've got my hands round the front of the spine, just trying to slowly cut that bit by bit. The biggest concern we've now got is as we manipulate his tumour and attempt to get it out, we could see his blood pressure shoot through the roof again. And if he gets a high blood pressure and it's sustained, he's at increased risk of having a stroke, and that obviously can give catastrophic neurological damage. And it's just slowly starting to come out. And here we go. Here's your tumour. That's what we've removed. So that is the tumour. That's the cut surface of the vertebral bodies. That is the groove that the spinal cord was sitting in. We've achieved what we set out to achieve. We've taken the tumour out, and to the naked eye, it's all out in one piece. So the only thing left now is to get him into recovery, and when he's awake enough, just check he is moving his legs and that there's no damage to his spinal cord. So until the patient's actually awake, you don't relax.
So my patient today is 71-year-old Ken. Ken seemed to have managed all his life with a condition called paralysis of the diaphragm. The diaphragm is a muscle sheath between the abdomen and the chest, which has two functions. One is to help the lung to fill with air, and the other one is to keep the abdominal organ in place. In Ken's case, half of his diaphragm isn't working. All his stomach is now up here in the chest. The food doesn't drain well and he starts vomiting. He's been losing a lot of weight. You normally tend to have a lot of breathlessness. Patients will be very breathless with this condition. And indeed, Ken has quite a big deal of breathlessness, but he seems to have coped with that all his life. So this operation should restore some of that function. It is a rather big surgery.
Ah.
Hi, how are you?
I'm okay, I'm slightly a bit nervous.
Sure.
I've not hit the panic button.
No.
I don't think I had an option, to be honest. I think we've reached the point with this where the quality of life is sort of very restricted with the condition that I've got.
That's what's most unusual is how you got away with it for so long with a career in the RAF.
Yeah, as I say,
The good old days.
I kept myself fit. I'm 72 next Friday.
Yeah.
This is an opportunity to give me some quality of life back.
Okay, well, let's see if we can get you home for your birthday. That would be lovely.
Eating is difficult in as much that almost invariably I'm sick. It just comes back up again. And as the lung has been shifted up because there's no diaphragm to control it, I've become shorter of breath and so more or less operating on one lung. So when I'm going out and playing golf, it's a bit of a struggle. I'm looking forward to going into a good pub and having a nice drink with my mates.
So this is Kenneth's CT scan. So this is the right diaphragm, this is where the liver sits, and that's normal. The black area is showing the air inside his right lung. But as you can see on the other side, there is no lung there. Because the diaphragm muscles isn't working, it allowed his stomach and intestines to rise up into the chest cavity and to take over the area where his lung should sit. That is quite a thing. So for a palsy or a paralyzed diaphragm, this is quite an extreme case of palsy. So the idea is I'm going to use stitches to tighten the loose diaphragm. It will bring the stomach back down into the abdomen and stop it from going back up and will allow the lung more room to expand again. One of the challenges is the diaphragm is expected to be so thinned out that when we start putting suture to tighten it down, it will tear. And if it tears, then you have no diaphragm whatsoever left. There's an endless amount of possibility of things to go wrong.
Hope it goes well.
Yeah, it's good. See you in a bit.
I'm pretty confident that you're gonna have something to work with.
No pressure. Good, good. We always do a little mental rehearsal of what the steps that we're going to do. Usually work out everything that could go wrong and how we can deal with it. So this surgery is a keyhole, which is less invasive. This will be less dangerous for all the patients and allow them faster recovery. Equally, it makes the surgery more challenging. So it's a trade-off. The challenge is that Ken's organs have moved dramatically inside him. Okay, so basically we're right on top of the chest, and this is the diaphragm. So yeah, that's the heart beating in the corner there. Hopefully, try not to disturb it. It won't disturb us. And we've got CO2, yes?
CO2, yeah. What do you want the CO2 set at?
Let's start with 10. We will fill the abdomen with CO2 to inflate the chest cavity, giving us more room to maneuver inside. Can we go to 15, please? We've got a bit more space to work with now. CO2 magic.
Yeah.
Oh, this is paper thin diaphragm. Look at that. I could see the bowel through it. It's almost transparent. I'm slightly concerned about how thin that diaphragm at the moment. So I need to tighten the loose part of Ken's diaphragm with stitches, and I need to bunch up this bit of redundant tissue. But my concern is that the diaphragm might be too thin to hold the stitches safely. If while I'm doing this procedure, the diaphragm rips, we will end up with what we call a hernia, a scenario that could leave Ken in much worse state than he is right now. Oh my. Is it worth attempting even?
There, so I'm in the defect now. Before we can fix the hole in Margaret's skull, we need the material which we use to patch it. This material is fascia lata, which we take from her leg. Hassan, how are you doing?
I'm good, Mr. I'm just closing the skin off now.
Can I have a look at the graft, please? Fascia lata is a strong structure that is in the outer thigh that joins two ends of bone. So what we're looking for is the fascia lata has areas that are quite thin, and it's got some areas lower down that are much thicker. So here we've got a very nice strong bit of fascia lata. So we're just placing our graft, our fascia lata, just underneath the dura over that defect, and spreading it out so that it's got a really wide underlay. Precision in this particular surgery is really important. A millimetre or two out and we could be injuring cranial nerves, we could be injuring the brain. So we place our grafts to within sub-millimetre levels, and then it'll be more robust in being able to separate the nose from the very thin lining that was there, with CSF leaking out from the brain into the nose. Could I have, I'll have another piece of that fascia. Let's use this on top of that dura as well.
So it's like underlay, overlay.
Yep. And we'll have that just sitting out, which is kind of filling a little bit of that dead space that we created. It'll be a free graft, so it won't be connected to a blood supply, but it's Margaret's tissue, so it'll integrate very well. Okay, well, back over to you.
Then.
Okay. So now, closure. She can now hopefully get on with a more normal life and not worry that she's going to have the fluid that bathes the brain dripping out of her nose and that ongoing risk of meningitis, which was traumatizing for her.
Right, let's have a feel of what that diaphragm is going to look like and feel like. Half of Ken's diaphragm has been completely disabled for almost 65 years. But the body can only compensate for so long. He only has one lung working and he's struggling to digest his food. If he doesn't have his operation now, his quality of life will be severely affected. So this is that thinned out, paralyzed diaphragm, is very thin. I don't know whether we can bear and how far can we go. So the first thing I need to do is to determine whether the diaphragm is going to be strong enough to be pulled tight. At the moment, his stomach is sitting high up in the chest and squashing one of his lungs. So hopefully pulling the diaphragm tight will force the stomach down and it will give his lungs enough space to expand again. But having been like this for 65 years, there's no guarantee it'll work. Now I'm going to stitch the diaphragm tight. It will work like a barrier and prevent the stomach from rising up into the chest again. So because it's so thin, there's a real possibility that I could rip when I put the stitches in. And the worst case scenario, it will leave Ken in a much worse condition than before the operation. It's a nice operation when it goes well. They tend to be quite nasty. Can we get those Teflon pledget that I've asked? We might need them actually. To give the tissue some additional strength, I'm going to stitch some synthetic material onto the diaphragm. I'm hoping this will stop it from ripping when I tighten the stitches to hold it in place. So this is Teflon, medical grade. This is very durable and the best material for this job. Another pledget. But this is the moment of truth. This is where I need to put the stitches. I'm folding the diaphragm over itself to reduce its surface area. A diaphragm tummy tuck. In the next stitch. You're not trying to do the most pretty diaphragm. You're just trying to make a durable repair. The question is, have I done enough or have I done too little or too much? I'm thinking we're almost done. We're almost done. There's nothing more to be done. I'm just gonna make sure we haven't done any damage. But the only test is when we take the pressure off the CO2 and inflate the lung.
Can I have a scissors, please? Yes, please. Thanks.
Ken has lived without a functioning left lung for 65 years. If we can get this lung to inflate again, this will completely change Ken's life. But there are so many things that could go wrong. The left lung might not inflate, the stitches may rip. It's always a worry. Okay, let's inflate the lungs. Okay, let's see what's gonna happen to this lung now. Please don't let us down. We'll be in trouble. We've done a good plication. There we go. Come on, enjoy your new space. Almost filled the space. I am relatively happy. Time would tell. Okay, scissors. I am pretty certain that he will notice that he's been breathless for most part of his life. We are as certain as we can be that there is no complications as a result of the operation so far, and it's all successful.
So today is just check on Gary, see his progress. So we need to see if he's up to standing. There's always the anxiety when patients wake up for the patient, will I walk again? And in the first few days, it's been tough for Gary. It's a big operation. He had quite a bit of pain. And he did question, is it worth it? There is that little bit of fear in the pit of your stomach until you see the legs move. Good morning. Is it still morning? Is it afternoon yet? Just gone afternoon.
Just gone afternoon. Oh, I got a clock.
How are we doing, young man?
Yeah, not too bad.
Making progress?
Making progress. Bit stiff.
Yeah?
Tired, but that's bound to happen.
Can we get to see you standing a second? What's the standing like?
Well, we'll give it a go. I don't mind.
Give it a go. There's always a degree of nervousness for the recovery. You assume everything will be okay, but you can't just say that it will be. In fact, there's probably more complications occur after surgery than during the operation. So the risk period isn't finished when the operation finishes. The risk period is only part way through. How does that feel?
Yeah, not too bad.
Just take your time. You sure?
Yep.
Don't push it if you're uncertain. Recovery is stepwise.
Yeah.
Okay. You want to push fast, you want to get home quickly, we all do.
Yeah.
Okay. But equally, I don't want you falling over and hitting your head.
Yep.
Okay? Okay. Give me your hands.
It's a bit.
How's that feel?
Yeah.
Okay?
Yep, not too bad.
Can you step? Okay, that's fine. Okay, should we sit you back down? There you go. I'm not going to push my luck too much.
The surgeon said I've got an allowance to be grumpy.
No,
I've got a pass.
not allowed to be good. No.
Yeah, I got a pass.
Yeah, no, but that's not happening. But we've got to control him because you know what he's like. He can't sit still for very long, can he? But he's got to be sensible. You have to put a lead on him to keep him tying down to the chair. Yeah? Yeah. Unbelievable relief. It's just been such an emotional journey. And my feeling now is just, wow, we can really think of the, we can really think that we've actually got a future together as a family, and we haven't had that feeling for quite a long time now.
There's still a way to go, but at least now we know all the tumour's out, everything's gone, and now that's all gone. At least now we can move forward. Because before there was no forward. And then we'll take it each day as it comes, really. All we can do.
He's doing reasonably well, actually. Very pleased with the way he's progressing. He's made of a very solid material, Ken.
Oh, Mr. Faloo.
Sorry, we woke you up.
No, Nearness.
I thought I'd come and say hi, really.
Hi.
How are you doing?
I'm fine, thank you very much. I'm on the mend.
You look a lot better than yesterday. It's amazing.
More colour in my cheeks.
I'm hoping it's less pain then.
There is less pain.
How did you tolerate your food today?
It's gone. In fact, there's no reflux, so everything's fine.
Lovely.
The first thing, as I was coming out of the anaesthetic, was the more comfort in breathing. And so you've made one hell of a difference, to be honest with you. I take my hat off to you, all the hard work you've put in, and I'm very, very grateful. 65 years with this condition. Extremely lucky to be alive.